All right, everybody, we're going to get back to it. It's my pleasure to introduce to you guys Dr. Elias from the University of Colorado School of Medicine.
Thank you very much. So it's my pleasure to be here at the interesting and exciting conference. Can you hear me?
Yes.
Perfect. So I'm going to talk to you today about an interesting syndrome, which many of you have heard about, and maybe some of you have not. The syndrome is called Ehlers-Danlos, named after the two different doctors who initially described it more than 100 years ago, and it really has not been until very recently that we've understood a lot more about it. That has been with the advent of new scientific testing technologies and so on that have allowed us to understand much better. So patients with Ehlers-Danlos can be sometimes incredibly complicated and incredibly sick. And other patients are pretty stable and do very, very well, and a whole big, huge spectrum in between. And so what I'm gonna explain to you this afternoon is about this diagnosis and how we make and confirm the diagnosis when we're able to do that. What are some of the complicated associated medical problems, and talk a little bit about some of the future possible treatments and research studies that are going on. So Ehlers-Danlos is actually not just one diagnosis, but actually 14 different forms of it at the moment have been identified. It falls into the underlying category, the underlying umbrella of what we call connective tissue disorders. Connective tissues are all of those tissues, your skin, your muscles, your ligaments, your bones, that are not your organs. There's a connective tissue disorder called Marfan syndrome that most people have heard of because it's been around a long time, and it has a very classic presentation. The swimmer Michael Phelps has Marfan, and he's a really tall dude with very long arms, helps him be a great swimmer. Loeys-Dietz is the newest disorder in this classification, named after two doctors who originally described it. And even though it's the newest, we know a little bit more about it because the genes for that condition, at least 4 of them have been identified. People with Loeys-Dietz in the old days, before we knew those genes, were often misdiagnosed as having one of the forms of Ehlers-Danlos, or sometimes misdiagnosed as having Marfan. And so there's a lot of sort of overlap in features between all of the connective tissue disorders, which sometimes makes it hard to be totally sure when you're seeing a patient which connective tissue disorder might the patient have. So just a couple of years ago now, in March of 2017, the American College of Medical Genetics, my college, reclassified the different forms of Ehlers-Danlos and helped really define what these different conditions are. And at the time they did that 2 years ago, there were only 13 subgroups, and then more recently, a 14th subgroup was identified, so then there are 14 types of Ehlers-Danlos. So the most common type is called the hypermobile form of EDS, and it's often abbreviated small h EDS. And this is an incredibly common disorder with an incidence something like 1 in 5,000 people. So very, very, very common. And most of my talk today is going to be concentrating on hypermobile EDS and the associated problems that can go along with it. but I wanted to give you a little bit of an explanation about some of the other forms of EDS. So Marfan, we know the gene that causes that, it's called fibrillin. And Loeys Dietz, there are 4 genes that we currently know and can do a simple blood test to confirm. But with Ehlers-Danlos, it's much, much more complicated. And there are many, many genes that can cause the different forms of it. But we do not know the genes that cause the hypomobile form. And I'm sure it's more than one. I suspect that there are genes that fall together in a pathway. So that makes it hard. I can suspect clinically by the patient's symptoms and their medical history that the person might have a hypomobile form, but I cannot do a simple blood test to prove it. So patients with Ehlers-Danlos display a whole wide range of symptoms and also a whole wide range of severity of those symptoms. And within that, since this is a neuroimmune conference, I think I was asked to talk about this because there are both neurological and immunologic issues that can be associated with in patients with EDS. So among the 14 known types, there are some that are exceedingly rare and not well understood for that reason. And then there are some that are much more common. But of all of them, the symptoms that one can see affect the skin and the joints predominantly, but then can also affect the heart, the GI tract, the autonomic nervous system, and there can be neurologic and immunologic consequences. So these are all genetic disorders, and you're born with it, therefore. You don't just get a strep infection and come down with EDS. You're born with this. And so therefore the symptoms start in childhood and progress through childhood and into adulthood, and can sometimes be associated with chronic discomfort and pain, and sometimes chronic disability. So because there are so many symptoms, patients can often be sent to a whole variety of different specialists. And especially in the adults that I've met, they've been sent all over the hospital. They might see rheumatology, they might see endocrine, they might see neurology, they might see a chronic pain team. And sometimes they've gotten different diagnoses from all of these many different specialists. And sometimes the diagnoses are not correct. And therefore the interventions that have been recommended might not be that helpful. And part of the problem too is that we don't have all of the answers for all of these interventions, and some of the treatments are still being developed, and for some of the recommendations, there's just not a whole heck of a lot of really good data and evidence-based research that's gone into proving that a treatment works or not. So that makes caring for patients with this disease much more complicated. And what I'm hoping to do today is to give you some updated information and some of the evidence-based approaches that we currently use to try to diagnose and manage patients with EDS. So what I learned about in medical school was what we now call the classical type of Ehlers-Danlos. And it predominantly involved the skin as the most obvious target organ. And in the classic form, in the more severe form, which used to be called type 1, people have really super stretchy skin. So you can take, the skin of their ears and pull them out to here, or the skin on the side of the neck and pull it out to here, or the skin behind the arms and pull it down 6 inches. Unbelievably stretchy skin. That's the classic type 1. And then what we used to call type 2 is a more mild version of that. So there are symptoms related to the skin, but they're just not as severe. And people with that classic form can have joint issues too. Their joints can be pretty double jointed, but their predominant symptom is their skin. So the classic types 1 and 2, we now know are caused by mutations in a collagen protein, collagen 5, 1A and 2. The hypermobile form used to be called type 3, and in that form, it's the joints that are the most predominant symptoms. So these are people, and kids can do this in an amazing way. They can wrap their knees around their neck, or they can touch their hands behind their backs in amazing ways. They can sometimes pop or dislocate their joints at will. So I have patients who can pop out their shoulders, pop out their hips, pop out their knees, pop out their elbows, and do this multiple times a day. Also the jaw, they can pop out, and that can lead to some long-term complications, feeding problems. So the hypermobile type predominantly affects your joints. And we don't know, as I mentioned, the genes that cause that form. But the hypermobile form of Ehlers-Danlos also has some skin findings. So very often when I'm examining those patients, the skin feels really soft, almost like a newborn baby's skin, really, really soft. And they have a little bit of stretchiness to their skin quite often. So I do all those maneuvers to see just how stretchy the skin is, and I often will find it's a little bit stretchy. And sometimes I've been confused or mistaken, and the patient I thought had the hypermobile form of EDS, I would do collagen testing and find a mutation in collagen 5, so what they really have is the mild form of the classic form. So there's a lot of overlap between these different types. And then the other of the 4 common types, the 2 classical, severe and mild, the hypermobile type, and then the other type that is reasonably common and I have many patients with is the vascular type of Ehlers-Danlos, and sometimes you see that as a small v EDS. And that used to be called type 4 EDS. And of all the types of Ehlers-Danlos, this is the type that can lead to complications that are probably the most severe because they involve your blood vessels are very, very soft and fragile, and so patients with a vascular form of Ehlers-Danlos can develop spontaneous rupture of arteries. So one of the fathers of one of my patients, they both had vascular EDS, the father was a totally healthy man in his late 20s, early 30s, walking down the street, and his hepatic artery ruptured and he died on the spot. So that vascular form of Ehlers-Danlos can be very, very scary because of that potential. There are 2 other things that can happen with that vascular form of Ehlers-Danlos. Patients can develop problems with their intestines because the intestine, particularly the colon, is very fragile too. And so these patients can spontaneously perforate their bowel. And in my patients with this, my pediatric patients, one of the things I have to do is just really, really keep on top of constipation, because constipation is just really common with this condition, and you want to keep things moving as much as possible and not let the stool become impacted, because that raises the risk of perforating the bowel. And then the third thing that you can see with this vascular form that can be very scary for women is that during pregnancy, the uterus can rupture. And so I've had patients whose moms almost died during delivery because the uterus ruptured. So that's the vascular form of Ehlers-Danlos. To me, the most scary form. So as I mentioned, the classic form, skin is the predominant thing, soft and velvety, stretchy. They also can have really, let's see if that will pull up. Oh, it's on my next slide. The skin, there are scars that are really unusual. They look really thin, they look stretched out and widened. And easy bruising is really common, so just mild trauma, like a little kid running around on the playground can come home and be covered head to toe with bruises. I've had families that have been incorrectly accused of child abuse because the kid looked like he was beaten up, and it's just that the skin is fragile and bruises easily. And then again, the classic form has mild joint hypermobility, and you see mutations in these two forms of collagen 5 causing that. And here's just a picture for you, a little bit of the stretchiness of the skin and that abnormal looking scar that you can see. They, in people who have surgery with Ehlers-Danlos, sometimes the surgeon has to go back and stitch them up a second time or third time because the scar doesn't form very well. And here is the vascular form of EDS. We know now that this is caused by mutations in a different collagen called collagen 3. Collagen 3A1 is the gene that is associated with the vascular form of EDS. We can make this diagnosis with a blood test. And although insurance companies often give me a big argument and a fight when I want to send a special expensive genetic test, this is one that I fight for and I win. Because if I'm suspecting vascular EDS, there are so many complications and changes in management that that I can convince them to do this simple blood test to prove this diagnosis. And then, as I mentioned, patients with low disease in the past, before we knew those genes, were often misdiagnosed as having the vascular form of EDS, and they can also have vascular rupture as well. But but that condition is caused by different mutations in another set of genes. So the skin, I'm not sure that displays perfectly well, but the skin, in addition to being stretchy and having unusual scars, can also look almost translucent. So you're looking at the kid's chest and you can see every vein in the chest. The skin looks very thin. And that is a fairly classic thing that I see in a kid with vascular EDS. And because the skin is so fragile, not only can you bruise easily, but you can also bleed easily. So just a teeny little scratch, the kid might have huge bleeding from that, or easy nosebleeds are pretty common too. And then there are other rare forms of EDS, 10 other forms, and they're caused by a whole host of other genes. And again, we can test for this easily with a simple blood test. We can do something called an Ehlers-Danlos panel, and all of these genes would be on that panel, and so with one simple blood test, I can, if I'm suspecting one of these more rare forms of EDS, I can get a definitive answer with that blood test. So the vast majority of the forms of EDS are passed on as an autosomal dominant disorder. So what that means is you only need a change in one of your 2 copies of the gene to cause this disease. And if a parent has it, there's a 50-50 chance of passing it on with every pregnancy. So very often I see an affected parent plus more than one affected child in the SIPship. And because particularly the hypermobile form of EDS is so common, I see a lot of affected parents, And some of the misdiagnoses that I've commonly seen in children, they sometimes are misdiagnosed as having arthritis, juvenile arthritis. And in adults, far and away, I think the most common misdiagnosis that I see is fibromyalgia. So when I'm taking a family history, I ask about that in the parents. And if the mom tells me she's had that diagnosis, I think, well, actually, it might be that your child and you both have EDS. So we've known for ages and ages, really ever since the 1980s, that collagen had something to do with Ehlers-Danlos, because if you take a little tiny piece of skin and you look at it under the microscope, collagen fibrils normally line up in sheets that are all parallel, but with EDS, the collagen is very disrupted, and also if you're looking at them on hand, instead of all being the same size and shape, you'll see big ones, small ones, and so there's a disorganized pattern and changes in the size of the fibers, and that can be a helpful clue before we had simple blood testing to make a diagnosis of a suspected collagen disorder. We still do this now on a more research basis. We're not really looking at collagen as the standard way to make this diagnosis, but we can with people with the rare forms and in the research lab, looking at other tests, we can see disruption of collagen in people we suspect have a connective tissue disorder. So I'm going to talk about, in the next part of this talk, some of the other problems in addition to skin and joints that I see in patients with Ehlers-Danlos. And I was asked a number of years ago now by the GI group at Children's Hospital who were treating patients with inflammation in your gut called eosinophilic esophagitis, which gave them terrible abdominal pain, vomiting, poor weight gain. And they asked me, why do so many of our patients seem like they might have a connective tissue disorder? They're really double jointed and their skin is really soft and weird. And what's the connection? And at first when they asked me this, it's like, that's a good question. So I started to do some more research, and that was one of the questions that got me interested in this disease and in thinking about this. So first of all, a little bit about collagen itself. It's a protein that's everywhere in your body, everywhere. It's not just in your skin and not just in your joints, but it's also in your blood vessels, it's in your intestinal tract, it's in your eyeballs. So kids who have brittle bone disease or osteogenesis imperfecta, their eyes look really blue instead of white because they have a collagen 1 mutation that makes that skin look be really fragile, and so you can see the vessels behind it, gives it a blue color. You have collagen in your lungs, and collagen is a protein, a stretchy protein that's really important for your lungs to expand and contract. So people with collagen disorders often have respiratory disease. And in fact, in collagen 1 mutations with the brittle bone disease, the patients with the most lethal form of it who die, they die because of respiratory failure. So the lungs are an important tissue where collagen lives. But to understand how collagens and other proteins that live in your extracellular space can also affect other problems too. I came across this slide, which was published in the paper talking about Loeys Dietz. So this was came from the first paper that described why patients with Loeys Dietz had GI problems, including eosinophilic esophagitis. So below that line is the inside of your cell, and on top of that line is the space, the extracellular space, which is the space between all the cells, right? And so there are proteins that live out there, including collagens. That's where collagens live. There's a protein called fibrillin, which is important in how connective tissue proteins connect and form a matrix, and that lives in your extracellular space and causes Marfan. And then there is a very important pathway called your TGF beta pathway that is important for multiple turning genes on in the nucleus of your cells. And it was discovered that Loeys-Dietz, that condition that looks like sort of some overlap with both EDS and Marfan, there are 4 proteins that are involved in that. There are receptors for TGF-beta in the cell membrane, that gray line going across, and then there are proteins down here in the SMAD complex that also, if they are mutated or changed, can cause Loeys-Dietz. And all of those are turned on, these proteins are turned on by this compound TGF-beta, connected with those receptors, activating this complex, and then sending messages to your nucleus that leads to making genes. So if something is wrong and you can't read messages, if these receptors are connecting with TGF-beta, then you'll trigger this. You won't be able to have this cascade functioning in a normal way. And the cells that make TGF-beta are called your mast cells. They're kind of immunologic cell. And so all of these genes that have nothing to do, in particular with mast cells, are affected if there are mutations that can't respond to that one chemical TGF-beta that the mast cell is trying madly to make. So genes work in pathways, and that's one of the sort of exciting and also confusing things in genetics, is that you don't just have to know one gene. You need to know many genes, and you need to know how genes interact. And so I'm certain in my mind, once we discover the genes causing the hypermobile form of EDS, that they will all be interconnected. And so one gene may trigger more joint issues, and one may trigger more GI problems or immunologic problems, but they will all work together in some way. It's part of the beauty and also the complexity of how your bodies work. So I want to talk just for a second about joint hypermobility. There's something called the Beighton scale. The Beighton scale is the only scale that we have clinically to assess just how double jointed a person is. The total possible score you can get is a 9. You get 1 point for being able to get your pinky way back over 90 degrees. So 1, 2, 3, 4 by being able to touch your thumb to your forearm. This. 5, 6 by being able to hyperextend your elbows. 7, 8 by being able to really bend back your knees. And then 9 is being able to touch the ground with your flat hands and your knees straight. So I will often, when I'm examining a patient for possible EDS, do a Beighton score. But this score is terrible. Doesn't help me. Because what if my patients, their main problem is that they keep popping their hips in and out, and they've needed hip surgery at the age of 10. Or they keep popping their shoulders in and out, or they keep popping their jaw in and out. Not measured on the Beighton scale, right? So I can have patients who are really super hypermobile and can have a Beighton score that's low. And so it's a problem. Patients with EDS, mostly joints, and they often have a positive Beighton scale, but not always, depending on which joints are mostly involved. They can have more mild problems with their skin, but the thing that brings them to come see me mostly are the other problems that patients have when they have EDS. And there are a whole host of these that I'm going to spend this part of my talk talking about. So I'm going to save the neurologic and the immunologic ones to the very end because that's the punchline, but I'm going to talk about the cardiac, the GI, the pain, and the mental health issues that I see. So one of the things that is really important for me to say is not every patient has every symptom, okay? And not every patient has every symptom in a severe way. And even if you've inherited this from your parents, you can have a parent who's very mild and a kid who's more severe, or vice versa. So when I talk about the cardiac issues, they're both anatomic and functional issues. So the anatomic ones can be mitral valve prolapse and a vascular fragility, particularly of the aorta, and we can see both of those with an echocardiogram. So an echo is one of the routine things I recommend. And then there's the functional issue related to how the heart is working, and that basically involves symptoms involved with your autonomic nervous system and your ability to regulate your blood pressure and your heart rate. So some of my patients, they go from sitting down to standing up, and their heart rate will go up over 150, and their blood pressure will drop really low and boom, pass out of the floor. Those POTS symptoms are extremely common, particularly associated with the hypermobile form. I've seen them in the classic form too, and they can be incredibly incapacitating because if every time you stand up and pass out, you can't work and you can't go to school. So that's why some of my patients come in wheelchairs because their POTS is so bad. The other symptoms that you can see related to dysautonomia can include feeling dizzy or lightheaded. Sometimes vision can be blurry. Sometimes there can be a little tremor. You feel anxious if your heart is beating really fast. You can sweat. You can feel nauseous. Palpitations because of the heart going so fast you feel like you have palpitations. And headache can be a dysautonomia symptom as well. The blood pressure, usually dysautonomia leads to a drop in blood pressure, although I've seen some patients with hypertension as well. And one of the really important things is that if your doctor's trying to measure you for this, it's important that they're taking the time. It takes at least 10 minutes sometimes to really be able to pick up the changes in these treatments. So the mainstay of treatment is giving extra fluids and extra salt. And for many of my kids, most of my kids I would say, this is all you need to do. Lots of extra fluids and extra salt. The salt can be salt tablets, and it comes in lots of different forms. You can add to water, or just add it to your food. For my teenagers, I tell them I want them to drink at least 2 liters a day. And I hope that that is all I have to do. And usually, very often, there are some rehydration solutions I listed up there that can be helpful that give you the extra salt as well as the fluids. I try very, very, very hard to not go down that slippery slope of needing IV fluids. Okay. If you need to give IV fluids a lot, like 3 times a week, then sometimes people will think about putting in a central line, Mediport or Fovea, and that is where the complications can happen and that are sometimes lethal because a patient can get lots and lots of infections in those central lines that take the bacteria directly to your heart, and it can be a lethal infection. So I try super, super, super hard to not have to go there. And then there are a number of different medications that have different properties that are used if the usual conservative things don't work. And a number of them have been tried, and the thing that is so hard for me as a pediatrician is that even in the adult literature, there's not good data about how these things work, what are the correct doses, And what are all the side effects? And in the pediatric population, there's nothing. And it's really scary when I see some of my patients have been put on super high doses of medicines that there's not even good adult literature for, and have had very serious complications and side effects. So you have to be super, super careful about that. The GI issues, the constipation, very common, and chronic abdominal pain, very common, and dysmotility. We've heard talk from an excellent adult gastroenterologist during this conference, but these problems can really start during childhood, and some of my pediatric patients have severe dysmotility at a young enough age that they've needed interventions, including special high-cal formulas, and sometimes other interventions, including feeding tubes. So we try to treat with medicines that are approved in pediatrics for reflux, acid blockers. There are lots of different special formulas now that we use. And in the doc session across the way, I asked the GI doctor, Dr. Pace, about allergies, because in pediatrics, we see a lot of food allergies that are causing inflammation in the gut that can lead to and worsen these symptoms. And the only way you can really address them in part is a diet that's restricted and things you're allergic to. And then there's a fairly more recent appreciation that that mast cell inflammation can occur both inside the gut as well as on their skin and lead to inflammation and a lot of the severe symptoms. And the medicines we use for mast cell are very often not on the medicine list of the patients who are coming to me. So it's something new that I'm starting to think about. If they're not responding to the usual ways that we're treating their abdominal pain and feeding problems, I'll think about adding medicines that address mast cell issues. And I mentioned when I was talking about the vascular EDS that treating constipation, it sounds dumb, and a lot of my teenage patients don't even want to talk about it, but it's one of the most important things I can do to help them. Chronic pain is a common problem in these patients, and if you're popping your joints in and out all the time, it's natural, it makes common sense that you can injure those joints and cause chronic pain. I'm fortunate to have a multidisciplinary pain team at my hospital, and very often I need to get them involved. And what can complicate this is that many of the pain medicines are constipating, and that just throws out your whole GI tract too. The mainstay of pain treatment is physical therapy. And I recommend that in all of my patients, particularly those that are experiencing pain. Maintaining movement and keeping your muscles as strong as they can be is really important. And there's something called the Levine protocol, where you start slowly and you build up your muscles in little small increments that can be very, very helpful. Psychological comorbidities are extremely common, and anxiety and depression we see quite a bit, especially in my teenage patients. And to me, it makes total sense that if you have a chronic condition, or you used to be a healthy, athletic kid, and now you're in a wheelchair and you can't go to school, that can make it pretty sad. So thinking about it, making sure a person is getting good support, mental health support, and sometimes antidepressants can be helpful. Some antidepressants also are helpful for some of the GI symptoms too. And getting good psychology support is really just part of the picture of total care for the patient as well as other people in the family, including siblings and parents. What drives me crazy, absolutely crazy, is when my patients show up in the ED and they're told this is all in their head. It is not all in their head.
Amen.
Amen.
Or don't go looking for zebras.
The zebra is the theme of the Ehlers-Danlos Society in London. I mentioned already the easy bruising and bleeding that you can see. Iron deficiency, I just wanted to take a second to mention that. Iron deficiency is incredibly common, in these patients. It's common in kids with eating disorders. What gives you iron? Red meat. What's the hardest thing to eat? Red meat. You can also get iron from beans, from green leafy vegetables like kale and spinach. Kids eat those too. And so it's really hard to get iron in your diet. I treat a lot with iron. I measure ferritin, which is the iron test. And I can, if your ferritin is in the basement, then your sleep is terrible. And if your sleep is terrible, all your other symptoms go to hell in a handbasket. So I always check iron and want to address the ferritin level. The perfect ferritin level is 50. Okay, so it might look in the lab that you're done that it's normal, it's 20, no, 50 is where I want it. And then obstetrical complications, uterine rupture I mentioned in vascular EDS, but premature delivery and bleeding are common complications in EDS. Immunologic issues. I'm going to talk about mast cell activation. It's very hard to confirm this diagnosis. It's easy to suspect it, hard to confirm it, because the definition of this in the immunologic literature is a little bit different from what we see in our patients. So these are symptoms of mast cell activation. I pulled these symptoms from that American College of Medical Genetics from March 2017. It had all these very detailed descriptions of these different things you can see with EDS. So skin, hives, rashes, flushing, asthma, we talked about respiratory stuff. You can have a runny nose and allergy-like symptoms and itchy eyes. You can have bloating, you can have diarrhea. You can have the POTS symptoms we talked about. And there are kids that look like they're having a severe allergic reaction, that they're having an anaphylactic reaction, but you do allergy testing and they come back negative. Mast cell. And we're learning more and more about this, and I'm getting my immunologic friends on board to make this diagnosis more often. There's a blood test called a tryptase level, which an immunologist or an allergist would often run, and they'll tell my patients, oh, you don't have mast cell, your tryptase is normal, but a normal tryptase does not rule out mast cell activation. There's some other tests in the urine, but you have to do a 24-hour collection. That's a pain in the part of one's anatomy. Get that? And more recently, we're doing tissue biopsies for kids who are going for GI procedures, and we can document mast cells in your stomach, in your esophagus, in your duodenum, in your bladder, that are associated with symptoms in all of those cases. There are lots of medications we do now that can help control some of the mast cell symptoms, and I try to make sure that my patients are on some of the typical allergy medicines, Zyrtec, Clomolin, Singulair. And then we talk a lot about trying to take away things from their diet that have set them off in the past. But this is probably the hardest of all of the symptoms to try. And one of the definition of the criteria is seeing if the patient gets better if they respond to the medication. So I find a low threshold for trying that at least. And then in terms of neurologic issues, this is a very controversial area within genetics and within neurosurgery. Headaches, migraines are really, really common. It's important sometimes to have a good neurologist familiar with EDS who's following you if you have these symptoms. A subset of patients have something called a Chiari malformation, where part of the brainstem slips down into the upper part of the neck, and that can cause both headaches as well as some neurologic changes in your arms, and you can actually surgically correct that. How many people actually have Chiari severe enough to need correction is sort of controversial depending on who you're talking to. And then the most controversial of all within neurosurgery is if people actually have craniocervical instability where there's too much movement. You can only see this with an MRI that you're doing in different positions. You won't see it on a normal MRI. And whether that is putting pressure on some nerves and causing headaches and other neurologic symptoms. The neurosurgeons in this part of the country don't believe in this so much. And so some of my patients have had to go to the East Coast to have surgery. I really am ambivalent about it because the patients that I know who've gone and had this major surgery, I'm not sure how well they've done in the long run. So I'm trying to keep an open mind. There may be some patients who truly have this. The neurosurgeons all over the country are planning a scientific study to really better understand, is this a problem, how severe is it, and what's the best way to manage it. And this is just a picture of your tonsils are going down into your neck and sort of sitting on your brain. And you can put pressure on the spinal cord, the nerves coming up from the spinal cord. So other patients have had muscle weakness, tremor. A lot of patients have this brain fog and learning problems. Some have seizures. It's difficult. These can be difficult to treat, and I really work closely with my neurologic friends, and we do have good neuroimmunologists that can help me with some of my more complicated patients. And I have been able to do genetic testing and have seen some very rare neuromuscular disorders on whole exome sequencing that have given a better explanation for some of the neurologic symptoms. So as I said before, and I really want to say this again, can't emphasize it enough. Not every patient has every symptom, and not every patient has a symptom severely if they have that symptom. So this can be a scary thing because everybody now goes and looks up Dr. Google and they find all the things that can possibly go wrong if they get this diagnosis. But it's not severely debilitating in all of my patients, and then most of my patients actually are very functional and have excellent qualities of life, go to college or are active and do really, really well. If you were paying attention, a lot of the symptoms of all the different problems go together. So you could be seeing a GI doctor for some of these symptoms, a neurology doctor for some of these symptoms, a rheumatologist, and they're each going to have their own little siloed approach to how they want to manage you. And that's part of the difficulty and the frustration of all of this, to try to put it all together and figure out what's really going to help. Because really what we want is to help our patients and have them be as healthy and as well functioning as possible. But because the symptoms are big, it's difficult to figure it out. It's just hard. Even if you know a lot about this, it's hard. And there are a lot of conflicting approaches, and there's just not good evidence base. There is not to prove that one thing works better than another. So what we really need is research to prove some of these things. So what can you try to do? I am thrilled. I think I'm thrilled, either that or I'm crazy, but a very generous philanthropist has just given a lot of money to create an Ehlers-Danlos program on campus at CU. And that will include a clinical piece. It will include a genetic testing piece that I can send expensive genetic tests without having to charge families for it. And eventually, when I can be able to look at not just whole exome sequencing, but also be able to look at something called whole genome sequencing, where I can look at the part of the DNA that's between the coding regions, and maybe the answers are there. It's one of my thoughts or theories. We don't know, but we have the potential and technology now to try to go there and to figure this out. There's a researcher, Dr. Roop, on campus who's doing some pretty cool research devoted to Ehlers-Danlos using pluripotent stem cells, and he can look at DNA, RNA, protein, he can look at cells under the microscope, and has started to look at some of my patients with some really fascinating and interesting results. So where do we go? The new multidisciplinary team will have a number of specialists, and depending on what the patient needs, we'll just have them see that particular specialist. You don't have to see everybody if you don't have that problem. We're going to be, what's really exciting to me is collaboration with the Colorado Center for Personalized Medicine. Personalized medicine is the wave of the future in genetics to really understand what your specific genetic information is doing for your health. And so we have this collaboration with the center. We'll be able to do exome, eventually whole genome sequencing, as well as creating a very, very detailed database and patient registry so that I can put together symptoms with the genetic studies that are being done. And so this is my last slide. This is a complex set of disorders, starts in childhood, autosomal dominant. For the most part, puberty and hormones sometimes make things worse. We need to understand that better. And the approach, just because it's so complicated, must be coordinated and multidisciplinary to really help most. And that's it. I'd be happy to take questions.